Hi, and thank you for joining our talk today. My name is Dr. Shivani Shah. I'm currently a GI fellow at UC Davis, and I had the opportunity to work with my mentor through the American Liver Foundation, Dr. Aparna Goel from Stanford University. Today we'll be talking about quality of life and cholestatic liver disease. Before we get into discussing quality of life, I would like to provide a brief background on primary biliary cholangitis, or PBC, and primary sclerosing cholangitis, or PSC. PBC is a disease characterized by the destruction of bile ducts within the liver, but normal appearance of bile ducts on imaging. It is commonly associated with an antibody called the anti-mitochondrial antibody, which can be positive in 90 to 95% of patients. It is more common in women. Symptoms at the time of presentation may include fatigue, itching or pruritus, and yellowing of the skin or jaundice. PBC is also commonly associated with Sicca syndrome, which is dry eyes and dry mouth, in approximately 50% of patients with PBC. Switching gears to primary sclerosing cholangitis, this disease is characterized by stricturing and dilation of the bile ducts, both inside and outside the liver. PSC is strongly associated with other autoimmune disease, particularly inflammatory bowel disease. Approximately 80% of patients with PSC have ulcerative colitis, and approximately 10% of patients with PSC may have Crohn's disease. Unlike PBC, PSC has a male predominance. Half the patients with PSC are without symptoms. However, similar to PBC, they may also experience symptoms of itching, jaundice, and fatigue. On the right of the slide, we show how the diagnosis of PSC can be made. The top photo shows an MRI depicting changes to the bile duct that are common in PSC, which is the stricturing and dilation. And then the bottom image shows an image from a special type of endoscopy that evaluates the bile ducts, or known as an ERCP. With respect to treatment for PBC, our most commonly used medication is ursodeoxycholic acid, which is usually dosed at 13 to 15 milligrams per kilogram per day. Now, there are some drawbacks to ursodeoxycholic acid, including the fact that it does not improve symptoms of itching or other PBC symptoms. The other challenge is that sometimes it can be dosed up to 3 times a day, which can be challenging to remember to take. We usually do try to target that improvement in the alkaline phosphatase to less than 1 time the upper limit of normal for your lab. Other promising options include obeticholic acid, which can help with patients that do not respond to ursodeoxycholic acid, meaning if their alkaline phosphatase does not improve. But the biggest thing here is it actually can worsen itching. And we also want to worry about giving this medication to patients with advanced liver disease or cirrhosis of the liver. We also have some promising therapies in clinical trials, as listed here. Unfortunately, we do not have curative therapy for PSC at this time. Management of PSC usually involves surveillance, or basically watching for complications. We monitor with MRIs, with that endoscopic procedure called an ERCP. Sometimes patients may ultimately require transplant as well. We do commonly use ursodeoxycholic acid. However, it may improve liver biochemistries of our patients with PSC, but it does not correlate with change in transplant rates or survival benefit. Now, switching gears into talking about symptom management and quality of life in our patients with PBC and PSC, I'd like to start talking about pruritus or itching, which is present oftentimes in both patients with PBC and PSC. Can be commonly found up to 20 to 70% of patients and has many negative effects, including sleep deprivation, depression, social isolation, and worsened fatigue. As listed here, we have several medications that we can offer. This is a small selection of what was most commonly offered, starting with cholestyramine at 4 to 16 grams per day. The issue with cholestyramine is that oftentimes we have to dose this medication apart from our other commonly used medications, given that it can affect absorption. Next, we have rifampicin, which can actually worsen liver injury and liver enzymes, so we do have to keep a careful watch on the liver. Naltrexone, which can cause opiate withdrawal reactions and requires a slow titration. Sertraline, which is an antidepressant commonly used in treatment of depression and anxiety, can cause a lot of GI side effects, a lot of nausea, vomiting, especially in the beginning, but that gets better with time. And then doxepin. It's another medication that we can commonly use for itching. We use low doses, but it may cause drowsiness. About 40% of patients with itch are untreated. There are trials involving the use of PPAR agonists and IBAT inhibitors for the treatment of itch, which have been promising but not yet commercially available. We have some non-pharmacologic options for itch, which include keeping the skin moist and cool, decreasing water temperature of the shower or bath, using moisturizing soaps and lotions, such as Eucerin cream. Do not dry off completely after shower or bath, and then to try to sleep with fewer clothes and blankets. Fatigue occurs in up to 78% of patients and impacts quality of life, and unfortunately there are no specific drugs currently approved for the treatment of fatigue. There is significant room for improvement in the management of these symptoms. And fortunately, there are clinical trials underway for the treatment of fatigue in patients with PBC. Exercise programs and mindfulness may be beneficial. A clinical trial at Yale University funded by the American Liver Foundation has shown promising results in utilizing mindfulness to treat fatigue in patients with PBC. The most important thing I'd like to convey to you is to reach out to these support organizations. Recognize that you are not alone in your experience. Similarly, for patients with PSC, I'd like to also highlight some of these wonderful support organizations that are available to you, as well as some of the exercise programs that may be beneficial. There are many different types of pains and descriptions of pain. It may be helpful to further subdivide the type of pain into three main groups. Nociceptive pain is the physical pain that arises from actual damage to anything except for nerves. So, for example, having a sprained ankle or recovering from surgery might categorize nociceptive pain. It's very localized and it's easy to treat because we can use topical therapies. We can also use physical therapy, as well as some different types of medications or painkillers. Neuropathic pain is a disease of the nervous system. So it's basically injury to the nerves or to the brain or anywhere along those pathways. So some examples might be some patients that have diabetic neuropathy. Patients might report pins and needles type sensation. For this, we also have medications that we can use to treat this to make sure you are comfortable. And then finally, nociplastic pain is a pain that arises from your response to pain, but there's no clear evidence of tissue damage on examination or evaluation. And so for this type of pain, we actually can incorporate a bunch of different therapies, including integrative therapies such as biofeedback and mindfulness to help target your pain. There are also some medications that we can use in this type of pain as well. Main takeaway message is to please bring up any type of pain that you may be experiencing with your physician or provider and see how we can help. I would like to conclude by mentioning that we highly encourage discussing any or all symptoms that you may be experiencing, whether you suspect that they may be related to your liver disease or not, with your provider. Each patient may have a different disease course and disease trajectory, so it's highly important to us to personalize your care and provide as much support as possible to help you through this. I would like to end by thanking you for your time and thanking the American Liver Foundation for this wonderful opportunity. Thank you.